Good morning, everyone. I'm Neil Love from Research to Practice, and welcome back. We're at day 3 of our 5th annual National General Medical Oncology Summit. It's been really a great weekend, and particularly being able to listen to all these clinical research leaders. And today we're going to talk about breast cancer. We also really appreciate the Florida cancer specialists who we partner with for this event. And also for each one of these modules, we have a member of the Florida cancer specialists up here to co-moderate with me. As always, we will be talking about the use of unapproved agents and regimens, so check out the package insert for more information. So today we have a bunch of important programs, and we're going to start out with hormone receptor positive breast cancer. We finished out yesterday afternoon talking about triple negative and HER2 positive disease. Today we'll talk about hormone receptor positive disease. We have a great faculty, Dr. Joyce O'Shaughnessy, closest to me, Dr. Seth Wander. Joyce is from the Sarah Cannon Research Institute in Dallas. Seth is from Mass General Hospital. Dr. Erika Hamilton, who also joined us yesterday, also from the Sarah Cannon Research Institute in Nashville. I know they have a lot of great connections here from a research perspective with the Florida cancer specialists. Dr. Jane Meisel from the Winship Cancer Institute of Emory University in Atlanta, and our co-moderator, Dr. Uday Dandamudi from the FCS, also will assist me here to ask provocative questions of the faculty. And, you know, our goal here is to make you guys say, wow, that was a really good question. And just to get us in the right mood, here's our last version of, this is the breast cancer version of That's a Good Question.
Great question.
That's a great question.
That's a fantastic question.
This is really the most important question.
Terrific question.
Really important question.
That is an excellent question.
That's such a great question.
That's a great question.
So that's a great question.
That's a good question.
That's a great question.
That's a great question.
That's a good question.
I think that's a really interesting question.
That's another great question.
It's a really critical question.
That's a really brilliant question.
That's a wonderful question.
This is a really important question.
It's a good question.
Yeah, good question.
That's good.
It's really so amazing just looking at these faces, just what it's like for me every day to be able to meet with these people is just such a pleasure and an honor. All right, well, here we go. All day long, as always. We're going to start out with Jane. We're going to talk about the management of hormone receptor positive disease as we do all day long, hormone HER2 negative disease. And Jane has some good case situations for us to talk about as well. So take it away, Jane.
Perfect. Thank you so much for having me. So we'll go ahead and dive right in. These are my disclosures. And then the learning objectives for the next several minutes, we'll say, will be to review some of the latest data on adjuvant CDK4/6 inhibitors and talk about how we apply this data in clinic. As Dr. Love said, I've got some cases for you. We'll discuss some of the efficacy and safety outcomes from the phase 3 lidERA study as well, and how we incorporate that potentially into clinical practice in the future. And also talk about several ongoing phase 3 trials of oral SERDs in the adjuvant setting. So before 2015, we really just had a few different endocrine therapies for treating hormone-positive breast cancer. And after that, patients had to move on to capecitabine and then to IV chemo, which made prognosis and quality of life quite limited. In 2015, palbociclib was approved in the metastatic setting. Several years later, ribociclib and abemaciclib followed, and these drugs pretty quickly changed the landscape for patients with metastatic hormone-positive breast cancer. A decade ago, that happened, and as history has shown, the next step for lots of drugs that do well in the metastatic setting, especially if they're well tolerated, is to study them up front. We ask the question, can we cure more high-risk patients with early-stage disease if we use these newer agents in the adjuvant setting? Good questions. So the phase 3 monarchy trial, many of you may be familiar with this, and I won't belabor the study design too much, but just to say that this was a trial for patients with high-risk stage 2 and 3 breast cancer. You had to have at least 4 positive lymph nodes or 1 to 3 axillary positive nodes and several high-risk features to enter. And these patients were randomized to receive either abemaciclib, 150 milligrams twice daily for 2 years, along with endocrine therapy, or endocrine therapy on its own. These patients were then followed for multiple different objectives, with invasive disease-free survival as the primary one. And the latest data that we have from this is 7-year follow-up data. And you can see that these curves start to widen and widen pretty steadily after that 2-year abemaciclib treatment period, with now at 84 months a 6.5% invasive disease-free survival benefit in favor of the 2 years of abemaciclib. Distant recurrence-free survival, we also see that benefit, 5.1% at that 7-year time frame. And then in terms of overall survival, you can see that that curve is starting to widen a little bit too as we get further out here. And that's a tricky one because we know that patients with hormone-positive metastatic breast cancer, if they do recur, tend to recur a little bit later and tend to live for a long time. So we're going to have to follow this one out for quite some time, but it's interesting to see this trend start to emerge. So a case example. You have a 65-year-old woman. She undergoes upfront surgery for a grade 1 ER/PR-positive, HER2-negative invasive lobular carcinoma. And as is sometimes the case, there was a little more disease than met the eye. And this patient's final pathology report showed a 4.3 centimeter tumor with 4 out of 9 involved lymph nodes. The largest was 7 millimeters of involvement, no extranodal extension. She has staging scans done that are negative for distant disease, completes chemotherapy and radiation, and presents to your office to finalize her decisions about adjuvant endocrine therapy.
So why don't we go, before we continue on with this case, to Joyce and tell me a little bit about how you might think through this case of this patient with 4 positive nodes, and whether the fact that this is lobular in any way affects how you think about it.
She's right on the borderline. She wasn't eligible for MindAct or for our exponder. That was 1 to 3 nodes. And if her 21 gene recurrence score or her 70 gene signature, her mammoprint had been low risk, she would not have gotten chemotherapy if she was 3 nodes positive. And she's on the borderline of 4. I generally will send one of those in these patients. I don't treat all of these patients with chemotherapy if they have biologically really indolent disease. It looks like it's really hormonally driven.
All right, let's just focus on that first thought. Seth, this lady has 3 nodes. Would you send off one of these assays?
Yeah, I agree with Joyce. It's always a little bit of a challenge with these low-grade lobular cancers. You know they're going to be less sensitive to cytotoxic chemotherapy and more endocrine dependent. So I would feel more comfortable about it if she was within that 5 centimeters, 3 positive nodes. But I still think the data that Jane was just showing us is quite compelling for the adjuvant CDK inhibitor.
Well, but what about chemotherapy as per Joyce? Again, if she had 3 positive nodes and a low recurrence score, would you have offered the option of not having chemo?
Yes, if she had 3 positive nodes, less than 5 centimeter tumor, with a low-grade lobular, it's likely that the oncotype would be low, and I would defer chemotherapy.
And if it were a ductal carcinoma still?
Still, I think we would send the oncotype. She would be within the parameters of our exponder. And, most of the time with the lower grade tumors, it tends to correlate with a lower oncotype, but that's not always the case.
I wonder what we'd see if we asked, a national audience whether they would be okay holding off on chemo with 3 positive nodes. Anyhow, all right, so Joyce, let's keep going here in terms of hormonal therapy.
So, she's somebody who would get an aromatase inhibitor and would get a CDK4/6 inhibitor. She's eligible for both. A little-known paper published in European Journal of Cancer that I was a co-author on for the MA27 trial looked at anastrozole versus exemestane. And in a retrospective, exploratory, unplanned analysis, the lobular cancer patients did worse with exemestane. Exemestane gets turned into an androgenic metabolite, very, very clear, and it caused worse survival. And I had asked Paul Goss to do that subset analysis because I had seen that in clinic for the invasive lobulars. And so that's little known. But so I don't use exemestane for invasive lobular cancers. But anastrozole or letrozole. And with the 4 or more nodes, 60% of the monarch E population was 4 or more nodes. So that's generally my choice for the 4 or more nodes because of the preponderance of data in that group with abemaciclib.
What about CDK? Which one?
Abema. Yeah.
And how would you use it dose-wise?
Well, I generally start at 100 milligrams twice a day, unless somebody's very frail, elderly, multiple comorbidities or history of GI tox. I would start with 50 BID, but 100 BID is my starting point these days.
I was just flashing on the fact the first time I think I met you was in 2000. And and we were talking about docetaxel capecitabine. Was it XT?
Yeah.
Not talk about that too much anymore. All right, Jane, let's keep going.
All right, perfect. I did not talk to Joyce about this, but this patient did start on anastrozole, not exemestane. And then we also discussed adjuvant abemaciclib with her. And I think for many patients, like this patient, she's tired from chemo, from surgery, from radiation. She was expecting to require an aromatase inhibitor, but is taken aback a little bit by the idea of an additional 2 years of treatment that could involve neutropenia, diarrhea, and frequent lab checks. So to that point of dosing, the TRADE study was a study that looked at this, because in the monarchy study, even though it showed the benefit that I described to you, 18.5% of patients discontinued for adverse events, mostly diarrhea, and over 40% required dose reductions. So the TRADE study was a phase 2 trial looking at whether a dose escalation study for adjuvant abemaciclib would improve drug tolerability and potentially allow more patients to stay on treatment. This trial looked at 89 patients, and the way it worked was they started at abemaciclib 50 milligrams twice daily, did that for 2 weeks, then escalated to 100 for 2 weeks, and then escalated to 150. And escalation required good tolerability. Antidiarrheal medications were allowed. And the primary endpoint at 12 weeks was the rate of discontinuation of abemaciclib for any reason, or the inability to reach or maintain the 150 milligram dose.
So before you go on, Eric, I'm curious how you use abemaciclib, and both in the adjuvant and the metastatic setting, and what you see in terms of tolerability. We had a lot of discussion yesterday about diarrhea. It started coming up in our gastroesophageal program. Dr. Jen was talking about zanidatamab, which I didn't realize causes much diarrhea, but we told her about the abemaciclib study in terms of dose escalation. What's your experience, Erika?
Yeah, I do tend to start at 100. I don't start at 50. I find if I start at 50, it's hard to get people really up, but I do start at 100. I find that most people can get up to 150, but it's really a function of getting them kind of wise in how to managing their diarrhea and kind of not blowing them out of the water right away with full dose, and then kind of go up to 150. But, most patients I find actually can go up and can tolerate. It's really your body gets used to it. If you're not kind of starting a full dose right away. But I do start a little bit lower to start.
Uday, what's your experience with abemaciclib, and also do you dose escalate?
So in the beginning, when the abemaciclib was approved, I was using the higher doses, and then like the first few weeks are the tough times for the patient. Then I started using the lower dose and then dose escalate depending upon the patient response.
So Jane, this is an actual patient you took care of?
It's modeled on an actual patient I took care of, yes.
Incident, just curious, getting back to that 3 positive node thing, you think she would have been okay holding off on chemotherapy if she'd had a low recurrence score?
I do, probably. I think what's tricky is with that 4 positive nodes, we don't have data. But she was in her late 60s. She was in pretty good health, but was also, concerned about the potential long-term side effects of everything we did, including chemotherapy. So I do think if she had had 3 positive nodes, I certainly would have talked to her about the potential of holding off.
Okay, please continue.
Sure. So in terms of the results of the TRADE study, what they found was that 26 patients met that compositive endpoint at 12 weeks. 6 patients had to discontinue treatment early, and there were 20 that were unable to either reach or maintain the 150 milligram dose. So 30% of patients that didn't get to that total 150 milligram dose and weren't able to stay there, but over 90% were able to continue on therapy at 12 weeks. Diarrhea and neutropenia were the most common adverse events, but this dose escalation strategy did allow more patients to stay on treatment and to stay on treatment at the maximal dose than were seen in the monarchy trial. And as you saw, it was just a 4-week dose escalation protocol, so suggests that this strategy we're talking about of potentially starting lower and titrating up could very well be something that's beneficial in the real world. So I think some thoughts from the trenches of how we do this for patients. I mentioned that my patient was sort of taken aback by the concept of doing abemaciclib, and I think it's important for us to mention the opportunity of adjuvant CDK4/6 inhibitors at the beginning of the relationship with patients. They may not totally realize it or recognize it in the beginning when you're also talking about chemo and surgery and all these other things, but to just sort of float the idea so that they're not surprised when you mention it at the end. I also, like many of my colleagues, often will initiate at 100 milligrams instead of 150 right away. And I often explain to people that I'm doing this to mitigate toxicity and that we can titrate up if they tolerate it well, but we can stay at 100 if not. And I think that also helps to build trust and establish rapport between the doctor and the patient.
Joyce, what about the option of ribociclib?
It certainly is well supported by the data, as I'm sure Jane will show us. The Natalie data are just getting stronger over time. It was well represented. The 4 more nodes was also a good proportion of the study. So that would be also another option for patients. We really have generally therapeutic equipoise. Like I said, I tend to go for the form more because 60% of monarchy, but also the survival advantage now.
Okay, please.
Yeah, I would agree with that, and that's an excellent segue into talking about Natalie. So what about adjuvant CDK4/6 inhibitors for more moderate risk patients? So the Natalie trial was another adjuvant trial. Some key differences between this and Monarchie were that Natalie used ribociclib instead of abemaciclib. It was a 3-year intervention with the ribociclib as opposed to the 2 years of Monarchie. And then also this trial included a number of patients with slightly lower risk features. So you could be node negative if you were 2 centimeters or larger and had certain higher risk features. And then there were a lot of patients with N1 disease that didn't have the same high risk features as we saw in the Natalie trial. And this trial is a little bit newer, so we don't have the 7-year data yet, but we've got the 5-year data. And you can see that these curves, like the curves from Monarchie, do start to separate and separate further after you get out from that first 3-year ribociclib treatment period, with a 4.5% invasive disease-free survival benefit seen at 5 years. And then if you look at overall survival, we don't have anything statistically significant yet, but a little hint that these curves may be also starting to separate. So we'll move to another case example, and then we'll talk a little bit, I think, as we do this, about toxicities and some of the differences between the drugs. This is a 42-year-old woman who undergoes mastectomy for a T2N1 disease. This is ER/PR positive, HER2 negative once again. She had her surgery in 2023 and had a 2.2 centimeter tumor with 1 positive node. She receives chemotherapy, comes in for follow-up, and she started on letrozole and ovarian suppression already, and then started 400 milligrams of ribociclib daily very soon after it was approved. So she's been on this drug now for a little over a year. But she comes into the office today, tearful, explaining that she hasn't taken her medications, either one of them actually, for the last 8 weeks because she's so tired of feeling tired, and she's depressed. And her symptoms have actually been much better off endocrine therapy.
So, Seth, any thoughts about this situation?
Yeah, it's a common, challenging situation. The way that I think about this with patients is sort of the analogy I use is getting to altitude on an airplane, right? We're layering one treatment in at a time to try to figure out what's driving some of the symptomatology. The core, I think everybody here would agree, is the endocrine therapy, trying to get the patient on optimal endocrine therapy. And so what I do in this type of scenario is sort of put one component in at a time and see if I can optimize the symptom burden. I think what Jane might be alluding to here is a problem we run into. If they can't tolerate the aromatase inhibitors, sometimes they feel better on tamoxifen, which obviously is not our first choice in a node-positive, kind of moderate to high-risk situation, but then we can't give the ribociclib, and she doesn't meet criteria for abemaciclib. And sometimes we have to meet patients where they are, talk about the magnitude of benefit and risk, put in some supportive maneuvers depending on the symptoms. Sometimes it's hot flashes, sometimes it's arthralgia, sometimes it's fatigue. I find the fatigue actually to be harder to deal with than, for example, the hot flashes, where we have a lot of good tools.
So, Jane, I'm curious what your thoughts were in terms of what was going on here. A lot of possible reasons for her to feel tired and depressed, maybe psychologic for one. Of course, she had ovarian suppression also. Was she having hot flashes as well? What was your take on what was going on, and what did you do about it?
So many things. So, diving into it further with this specific patient who had some young kids at home and some home stressors and wasn't sleeping very well, we addressed that issue. And then also the issue of, having not ever been depressed before in her life. I think she had a little bit of personal stigma about that issue and whether she should receive therapy, whether she might benefit from an antidepressant. So we spent a lot of time talking about those things, and then also talking about the fact that, if we can, we really would like to get her back on some form of endocrine therapy soon, because this really was the thing that was probably doing the most in terms of preventing her cancer from coming back.
Do you usually suggest patients to try to exercise at this point in time?
Exercise for sure, if they're not already doing that, and we talk about that early on also. And I think really just trying to destigmatize any problems that they have, accepting the fact that they might need a little bit more help, just even reframing or wrapping their mind around everything they've been through.
How old were her kids, and was that a concern for her?
7 and 11, and absolutely. I think that there's that fear of recurrence and wanting to be there for your family, but also the sort of, I think, complicated guilt that people feel when they don't feel well because of their treatment, and they feel like they're missing out on events with their kids day to day.
Do you find that the kids actually know what was going on? Do you advise patients about that?
I do, and I think that different strategies work for children of different ages and stages. We have a wonderful social worker at our clinic who also is helpful with that. And I think as a parent to young kids myself, I do try to give some personal guidance and just try to get on the same page with my patients. This patient, I'll kind of fudge some of the details just for anonymity, but had a son around 7 and a daughter around 11. The daughter knew a lot, and I think that part was almost harder for the patient because she saw so much of herself in her little girl. The son knew less, but I think it was more about being able to be active with that little boy too, that she felt like she was missing when she was on these meds.
Okay, let's keep going.
Okay. So after discussion, and I'll kind of summarize this for now because we've got more to get onto, essentially she agreed to go back on endocrine therapy. We did dose-reduce the ribociclib, and I connected her with a wonderful therapist, and then we made a closer appointment for follow-up. She had been on ribociclib for a while, so we'd been seeing her every 12 weeks, but we pushed that back to every 6 weeks just so we could continue to connect on a more regular basis.
You keep going.
Okay. So in terms of adverse event management and adherence, I think one of the other things that case brings out is that the shift from IV treatments to mostly oral regimens has been a wonderful thing for our patients, but the drugs are only as good as their ability to take them. And so we have to make sure that our patients have all the tools they need to optimize adherence, since we're no longer guaranteeing this by administering these medications in clinic. With oral CDK4/6 inhibitors, especially now that we're having patients take these for longer durations of time in the adjuvant setting, we really have to make sure that patients understand the importance of taking these drugs as prescribed. So technology, I think, sometimes can be a helpful tool for this, and I did want to show you guys this slide just from a study that we published at Emory. This was a study where I partnered with colleagues of mine from our School of Public Health and also folks who have this app called TAPT, to determine whether this app would be feasible and usable in women with breast cancer who were prescribed a CDK4/6 inhibitor. So the way it worked is that women attached that sticker to their pill bottle, downloaded the app to their phone, and then they would scan the app every time they took a dose, and they would get symptom surveys to take biweekly. They received missed dose reminders if they missed a dose, and then if patients missed more than 20% of doses or reported moderate to severe symptoms, then that was reported to the doctor that was taking care of them and prescribing their CDK. We had 107 patients studied and pretty good CDK4/6 inhibitor adherence with the use of the app. And we're still studying some of the data, and there's more to come from this study. But we found that anxiety and depression were associated with lower adherence rates to medication. So for me, really just highlights the importance of assessing mental health and making sure our patients feel supported, because those patients who are struggling a little bit more with this stuff may be less likely to be able to adhere reliably. The next topic, and kind of last clinical topic of this segment, is thinking about ESR1 mutations and what's coming down the pike. So I think when we talk about metastatic disease, we'll talk a bit more about ESR1, but we know that roughly 20 to 40% of ER-positive breast cancer patients will recur with distant metastases. Some of these recurrences happen because of development of ESR1 mutations. These mutations change the shape of the estrogen receptor and lock it into an on position without the need to bind estrogen to promote cell proliferation. And then the estrogen receptor can signal the cancer cell to grow whether or not there's estrogen around to feed it. We now have 2 oral SERDs approved in the metastatic setting, and they're now being studied in patients with early stage disease. So we don't have oral SERDs in the early stage setting yet, but there was an exciting clinical trial that was presented recently, and I do want to discuss that with you. So this is the lidERA trial. This is a trial, a randomized study in patients with stage 1 to 3 disease, as you can see. So a little bit of a different inclusion criteria than the CDK4/6 inhibitor studies we talked about. This trial looked at giredestrant, 30 milligrams daily, versus standard of care endocrine therapy, either tamoxifen or one of the aromatase inhibitors. Now you can see that this trial was stratified into 2 groups: the high-risk patients, which are about 70% of trial patients. Those are patients with T4 disease, more than 4 positive nodes, or 1 to 3 positive nodes with some high-risk features. And then medium-risk patients, being the other 30% of the trial, kind of including everything else. And then you can see the primary endpoint, which again was invasive disease-free survival. And this is looking just at 3-year data, but you can see that there is a separation of the curve starting to emerge, an absolute benefit of 2.8% in favor of the giredestrant at that 32-month median follow-up time point. Overall survival, we don't see anything there yet, really, but I think this is something where there is a trend and where we'll have to follow these patients out for many, many years before we can draw conclusions. Adverse events with the giredestrant were pretty, manageable, I would say. Headaches, hot flashes, and arthralgias being the primary ones. There was about a 10% rate of grade 1 bradycardia, which is something to watch as we continue to learn more about this agent. But patients mostly did pretty well with low discontinuation rates. So the future of oral SERDs in the adjuvant setting, I think we don't really quite know yet where this is going to fall. We know that lidERA had a similar PFS benefit at 3 years as we saw with adjuvant CDK4/6 inhibitors at 3 years. And so if it does get approved at some point, we wonder, could it replace these agents in certain populations, especially if it's better tolerated and easier to take? Obviously, there's a lot to talk about there. Some limitations. This drug has not been studied yet alongside adjuvant CDK4/6 inhibitors, which does have a lot longer follow-up in the patients who qualify for that. And then cost, of course, could be a factor. There are a number of other oral SERDs and agents being studied in the early stage setting. Some of these in high-risk patients after they've already had 2 to 5 years of standard endocrine therapy, with camizestrant, imlunestrant, and elacestrant being drugs that fall into this category. So a lot to come in the future, for sure. Some conclusions from this segment. We know that in early-stage hormone-positive breast cancer, treatment options are quite complex, and we have to integrate our understanding of a patient's disease biology with their personal goals and medical history to help them make the best possible decisions. We know that for most patients, 5 years of endocrine therapy, sometimes up to 10, remains the backbone of treatment. And so we want to also think about who are the patients who benefit from that extended endocrine therapy and who needs CDK4/6 inhibitors. We know that abemaciclib or ribociclib are standard of care opportunities now for many of our higher risk patients, and that we can consider dose reductions or starting at a lower dose to mitigate side effects and help patients remain compliant while continuing to have good quality of life. And then future considerations, depending on what the FDA decides, could include giredestrant for a certain subset of patients in years to come, and other adjuvant oral SERD trials could potentially change practice. And it was outside of the scope of today's talk, but based on the DARE trial and other things, there could be a potential future role for monitoring ctDNA in these populations. I think, as we talked about, managing side effects proactively and ensuring that we have that whole village with us to take care of our patients, mental health providers, nutritionists, pharmacists, and others to help optimize compliance and make sure patients are continuing to feel well while we're helping them do as well as possible.
So a lot to talk about there. We were actually in San Antonio when the Ladero paper was presented, and we actually had a program that night. We had 5 investigators. I think, Seth, you were there. And we asked each one of them, what do you think, what are you going to do about it? And like everybody kind of gave a different answer. So I'm wondering now, a few months later, how it's getting sorted out. So I'll start out with you, Seth. What were your initial thoughts when you saw it? Also, another theme that's come out this weekend is, so many new agents we've been talking about this week. I mean, pancreatic cancer turned out to be a wild session yesterday, which I was not expecting. And also thinking about what it's like for a general oncologist when they hear about a study, how they hear about it, and how they figure out what they're going to do about it. But Seth, what were your initial thoughts about this?
I think every 20 to 30 years we're due for a new anti-estrogen class, so we're right on time. The lidERA data, I think, is very exciting for a couple of reasons. First, it expands the discussion about the next generation oral SERDs beyond just ESR1, because we know the rates of ESR1 mutation in the untreated early stage or metastatic frontline setting are exceedingly low. So it suggests that these drugs may be better. Now, the key question is, are they better mechanistically, or is there better adherence, because there may be better quality of life, lower rates of discontinuation? I think Jane brought up the most important practical question about lidERA, which is, if you look at the shape of the curves, they look a lot like NATALEE, they look a lot like the early shape of monarchE, but we don't have that 7+ years of follow-up. And we don't know whether that magnitude of benefit, let's call it 2 to 5% in terms of IDFS reduction, will hold in the patients who get adjuvant CDK inhibitor. So we're going to see that from studies like EMBER-4 and ELEGANT. If you treat patients who are node positive, who meet criteria for adjuvant CDK, and then make the switch to an oral SERD, do you stack that 2 to 5% on top of the additional benefit from the CDK or not? So if this were to get approved on Monday morning, it would be a hard conversation for a person, as Joyce was outlining, who meets criteria for monarchE, and you're excited about giving the abema because there's survival benefit, there's long-term follow-up. You technically would probably have to choose between the two of them, and I think that would be a very nuanced and complex discussion until we have more data.
So, Erika, do you think this is going to be approved? And if so, again, how are you going to think through the strategy? Also, of course, giredestrant is newer SERD, but I was kind of surprised to see the arthralgias being the same, because I don't hear about arthralgias with SERDs in the metastatic setting. What's your experience with this agent and SERDs in general in terms of side effects like arthralgias?
Yeah, I'll be honest, I was a little bit surprised. I anticipated seeing the giredestrant being a little bit better tolerated than the AI. But, I think that really reflects maybe not being super surprised that tolerability of drugs in the adjuvant setting is different than the tolerability of drugs in the metastatic setting. That risk-benefit ratio of a woman with metastatic disease taking a drug is very different than a woman that thinks that, conceivably she's cured administered and having to be on a medication like this for 5 years. So I'm, curious to see what some of the other drugs look like, tolerability in the adjuvant setting. Right now we really only have metastatic, but it wouldn't surprise me if, all of these drugs that look a little bit cleaner in the metastatic setting do have more side effects when we put them in the adjuvant setting. But I completely agree with Seth. I think some of these other trials that are coming now after giredestrant that, accounted for the presence of CDK are really going to answer this question for us of, can we have CDK and a novel endocrine backbone together?
So again, Jane, we're doing a session in a couple hours on colon cancer, colorectal cancer, and of course we're going to be talking a lot about cell-free DNA. What an incredible advance it's been there. You mentioned that in your presentation. First of all, what were your thoughts also? I'm curious about lidERA, if you had the access to treatment, if it were approved, how would you use it? And do you see ctDNA having a role in breast cancer in the near future?
Two good questions. So I think that my answer is probably very similar to Erika and Seth in terms of lidERA and how I would use it, because I do, in those patients who are CDK4/6 inhibitor candidates, I do feel like that longer follow-up data that we have and some of the more assurance that we have makes it for those patients probably a better option at this point. I think if I had lidERA and giredestrant available for patients who weren't candidates for CDK4/6 inhibitors or who couldn't tolerate either of them, that might be potentially a consideration. I have had some patients who, for example, have had a lot of diarrhea with abemaciclib, and I've had to switch them to ribociclib, and then they had LFT problems who couldn't be on either medication. And so I definitely see a role for that. And like in anything with breast cancer, it's nice to be able to have choice. So we'll see what happens as this medication is studied further and gets closer. And as to the cell-free DNA question, I think it's $1 million question. Definitely one that I think we're all grappling with, because many patients come to us either already checking ctDNA or wondering if they should be. And I do think that it was probably something that will have a role for certain higher risk patients. I was actually having this discussion in clinic on Friday with a patient of mine with stage 1 disease who came in and said she had friends who were checking it, and should we be doing that? Can we order Signatera? And I talked to her a little bit about the DARE trial and what the eligibility criteria were, and that I really had some hesitation about checking ctDNA in someone with stage 1 disease doing well in tamoxifen. So I think that more follow-up from the DARE trial and others like it will probably be needed to help us determine who should we be checking this in, and then what do we do about a positive result. But I do think it's going to make its way into the mainstream for sure, even more than it already has.
So I had the pleasure of working with Dr. Lars Posdai from Yale on a program actually on cell-free DNA, and I was looking through his CV, and I saw this paper he did on SEER data, where it showed that 23% of deaths from breast cancer occur in women who are initially stage 1, which makes me wonder, are we going to have maybe a few more strategy for those patients? Joyce, I want to know what your thoughts were about lidERA. Again, if you had access, what would you do about it? And also, do you think there might be a future for SERDs without ovarian suppression in premenopausal women?
I thought the data were stunning. I was very surprised at how fast the curve split. We saw that with ATAC, and the AIs were so much better, and that's turned out to be the case, particularly for aggressive, virulent cancers. And when the curve split that early, like, wow, there's a biology going on here that I was not expecting. So that was really, really good to see. We got to really think very carefully about that highest risk population. But, that first line persevera in the metastatic setting that looked at AI CDK versus giredestrant CDK in the first line setting, no difference. Because with the CDK there, you're getting such benefit that there may well be differences between AI and the oral SERD in the first line setting, but it's very hard to tease it out. We haven't seen the data yet. The press release said there was a trend, so we'll see, because we have multiple of these first line trials. But it was a bit of a cautionary note for how easily it's going to be to show an improvement in that upfront adjuvant setting, even in a very high-risk population. Nonetheless, I hope we get to do that trial. I think we need trials like that. We really do in a very high-risk population. The issue, so I think that, I hope we'll be able to use the oral SERDs with CDK4/6 inhibitors. In this trial, there's a safety group with 100 patients with abemaciclib. So there is a safety population. We're not going to have efficacy data. And then Cambria 2 is looking at about 30% of patients who have a CDK4/6 inhibitor with camizestrant. So that's a pretty sizable subset in an upfront camizestrant CDK versus AI or endocrine therapy CDK. So that's going to be another data set combining the two. With regard to women premenopausal patients, there was a study published by Joanne Zajewski from the NCI. We're going back 30 years ago now, looking at fulvestrant in premenopausal patients and looking at FSH levels and estradiol levels, and you do get that same rebound in the FSH, and you get the rebound in the estradiol. So that was with fulvestrant. So I haven't seen those data with oral SERDs. I think we need them. So I think for the foreseeable future, we'll be combining with an LHRH agonist. But I think it's a great question that I think is going to be studied.
So Seth, you have a patient who's on an adjuvant AI and is miserable. Would you, if giredestrant were approved, would you switch the patient to giredestrant?
Yes, I think certainly if the patient were not on a CDK and they were on an adjuvant AI, I would be pretty compelled by these data, both in terms of efficacy. And I would just want to make two quick points. We are addressing this question of ovarian suppression with the oral SERDs. We have a study opening soon at MGH called the Pre-EMBER study, which is, I think, open maybe at some other sites now. It's a preoperative window of opportunity, but it's premenopausal women without ovarian suppression getting imlunestrant. And we'll be looking at measures of Ki-67, cell cycle proliferation, et cetera, to try to generate some of this data. And the second point, to Erika's point, we'll see this in Serena 6, I think, later this morning. And Neil, I don't have an answer for this, but the patient-reported outcomes on these drugs, and anecdotally our experience giving them, suggest, to your point, that they feel better on the oral SERDs. In my experience, less arthralgia, less menopausal symptoms, maybe a little bit more low-grade GI toxicity. And you see that in Serena 6. In a double-blind study, you see the patient-reported outcomes switch almost immediately. And yet, to the point that you brought up earlier, the tables, in terms of the rates of arthralgia, don't look that different. And I can't really explain that because it's not my gut feeling in clinic. So the patient you alluded to, I would want to switch her because my feeling is that they do have less arthralgia and less menopausal symptoms.
So Uday, you wake up tomorrow morning, you check your phone, and giredestrant's approved in the adjuvant setting. What are you going to do?
So, one of the main things I have in premenopausal women is significant symptoms associated with the ovarian function suppression as well as AI. So probably I would try that. That would be my, if the data supports.
All right, Erika, we're going to move on and talk about first-line therapy of metastatic disease.
Yeah, absolutely. So let's start with endocrine therapy and CDK4/6. We'll go through this pretty quickly. As we all know, we have choices in first line. We have 3 agents. We have palbociclib, ribociclib, and abemaciclib. We all know that ribociclib, we have overall survival here. Abemaciclib, we have quite a spread in terms of absolute magnitude of overall survival, but it was not statistically significant despite the fact that there was a 12-month spread based on how the trial was designed. And with palbociclib, we do not have statistical significance with a hazard ratio of 0.96. I think one of the questions that I still see coming up, a lot of patients that I see in referral, is, this patient that presents with metastatic disease, maybe has some high risk features, visceral mets, kind of rapid progression. This question of, well, should I give them a little bit of chemotherapy first before I put them on endocrine therapy in combination with their CDK4/6? And I want to go through this just because we really do have a good body of evidence that we don't really need to do that, that CDK4/6 is sufficient. So this was the Right Choice trial, randomizing patients that had indication for aggressive treatment, symptomatic visceral mets, rapid progression, or impending visceral crisis to either getting combination chemotherapy with docetaxel cape, paclitaxel gem, capecitabine, vinorelbine, or endocrine therapy in combination with ribociclib. The majority of these patients, over 60%, had de novo metastatic breast cancer, and about 70% of them had symptomatic visceral metastatic disease. And as you can see, endocrine therapy with ribociclib outperformed combination chemotherapy by 9 months. So I think this is really compelling data here. When we look at subgroups, whether we talk about patients, visceral crisis or without visceral crisis, really ribociclib in combination with endocrine therapy was just as effective, if not superior, based on time to response rate, or progression-free survival. We also have Abigail. This was a non-inferiority trial of abemaciclib with endocrine therapy with or without induction chemo. So this was designed just a little bit differently, similar that everybody had at least one aggressive factor. They had relapse on adjuvant therapy. They had visceral disease, high grade, high LDH, et cetera. And the primary endpoint was kind of 12-week response rate by blinded independent central review. And you can see response rate was almost 60% with endocrine therapy abemaciclib and about 40% with paclitaxel. So again, I think a second trial really showing that our patients that are getting endocrine therapy in combination with a CDK4/6, this time abemaciclib, are having very good outcomes. So we don't really need to feel that if we're treating with CDK that we're not going to get a fast response, or for those patients that have visceral disease that we're somehow giving inferior treatment. So this was OMBRE. This was first-line trial of chemotherapy versus abemaciclib in combination with endocrine therapy. These patients had high tumor burden. They had not had prior treatment for advanced breast cancer. They had at least 2 visceral sites or at least 3 lesions in 1 visceral site. And again, they were randomized to either CAPE, paclitaxel, or endocrine therapy. And here you can see progression-free survival, again, favoring endocrine therapy with abemaciclib, 13.9 months versus 7 months. So again, quite a broad body of evidence with this concept.
So a quick question to Joyce. Any situations where you would use a chemotherapy first and then come in with endocrine therapy, lymphangitic mets, for example, respiratory failure?
Sometimes if patients are hospitalized, somebody comes into the ER and you've never even met them before and they have lymphangitic and we've got to quickly get them going on treatment. It's just easier to get them chemotherapy in the hospital than it is oral agents sometimes. But generally, the efficacy is so much better and it's so fast that it really isn't very clear. Now, occasionally somebody's bilirubin will be, 3 or 4. We don't have data, to my knowledge, with ribociclib and abemaciclib in that context, exactly how to dose it, but we've learned how to do mini doses of effective chemotherapy for these patients, so that might be the one spot.
All right, Erika, oral SERDs.
So the data here, obviously I think we're getting very familiar with oral SERDs, certainly high potency. We have activity against ESR1 mutant. We also have activity in wild type. I think the body of evidence is really growing there. It's not that we don't have activity in wild type. It's just that the activity in wild type hasn't beaten the activity of the endocrine agents that we currently have. And again, I think there's an increasing body of evidence that there are some areas where we have less toxicity. So this was the SERENA-6 trial. It was a first-line trial. I really like to call it kind of maybe a 1.5-line trial of ctDNA-guided switch strategy. These patients were already on AI in combination with CDK4/6, and they'd already been on this for at least 6 months. They entered essentially a surveillance strategy where they were getting ctDNA drawn and looking for an ESR1 mutation to emerge. If this ESR1 mutation emerged while on their AI and CDK4/6, then they were entered into the possibility of a randomization to continue the AI and CDK4/6 that they were already on, or to switch to camizestrant, the oral SERD, and continue the same CDK4/6 that they were on. So this is essentially switching your endocrine backbone with the emergence of an ESR1 mutation in the absence of progression. Now, if they had scans and they had progression, they weren't eligible to switch. So this is really kind of a biomarker-led switch only. So who were these patients? In terms of when we saw the ESR1 emerge, most of these patients had it at the first test. We saw about half that ended up having it at a subsequent test. So time from initiation of AI and CDK4/6, the majority of these patients were a little bit over 18 months. And you can see kind of a breakout of what ESR1 mutations they did have. You can see that all three of the CDK4/6 were represented here. The majority were on palbociclib. We had about 15% ribociclib and about 10% abemaciclib on SERENA-6. So this was the primary endpoint, which was investigator-assessed progression-free survival, definitely in favor of camizestrant in combination with CDK4/6, 16 months versus 9.2 months. And I don't think this really should be surprising to us because, again, an ESR1 mutation was emerging. This is a resistance mutation, so not surprising here. The secondary endpoint was progression-free survival 2. Looking here at PFS2, no significant improvement in PFS2 between the arms. Hazard ratio was 0.52, but you can see here the adjusted hazard ratio really favoring camizestrant CDK4/6. This curve is on top a bit, but a lot of debate around this trial, I think, really asking, kind of how do we interpret this? Because if you think about, PFS or PFS2, in some ways we're not comparing apples to apples here because despite the fact that, the patient hadn't actually progressed, we're introducing a new drug, even in the absence of progression. So in PFS, we're kind of comparing one line of therapy to 2 lines of therapy because they changed their endocrine backbone. And in PFS2, we're kind of comparing 2 lines of therapy to 3 lines of therapy in the other arm. And so some people saying, well, that's not really a fair comparison. And other people saying, well, we're changing therapy in the absence of progression. Perhaps this is in the patient's best interest to not let the patient progress. Perhaps they would have had symptoms if they'd progress and things of this nature. So in terms of adverse events, we certainly see neutropenia as the most common. This is not surprising. We're combining with a CDK4/6 inhibitor. We do see photopsia is more frequent. This is a side effect of camizestrant. What photopsia is a little bit of waffling of the periphery of the vision with changes of ambient light. So this is essentially you go into the bathroom, flip the light switch on first thing in the morning. They can have a few seconds of kind of waffling of the vision at the periphery. This does not affect actual vision. It doesn't affect reading. It doesn't affect driving. Most patients after a few months of this say that they don't have it anymore. I think they still have it. I think they don't notice that they have it anymore. But this is essentially an ion channel in the eye that camizestrant hits. When camizestrant goes away, the drug goes away. There's no actual changes in the eye. This has been well studied by the ophthalmologists on trial. But otherwise, pretty well tolerated drug. We can see a little bit of bradycardia, similar to the giredestrant that we see. This really is asymptomatic as well. Very low rates of discontinuation here.
So we actually had a CME program we did on ophthalmic issues in oncology. Always something different. And we actually were honored to have 4 posters at the San Antonio meeting. We always like to do surveys. We had a bunch of surveys. Seth partnered with that. And we saw some interesting differences there in terms of interpretation of SERENA-6, and I wonder if it's going to play out here. So, Erika, would you like to be able to use the SERENA-6 strategy, or you want to wait a while?
I think for the select patient, I'm not sure that I'm ready to start switching everyone based on the ESR1 at this point.
What kind of patient?
I think, really somebody that has kind of more of an aggressive phenotype, somebody that perhaps has an early emergence of ESR1 that's going to have more of a poor prognosis. I find it interesting because in the other CAMI studies, the earlier SERENA studies, our benefit of camizestrant is about 5 months. Compared to standard endocrine therapy. And so if you kind of take that benefit of what we see in this trial and you just say, okay, well, if I had just given those patients an oral SERD because the patients in the control arm, didn't get an oral SERD, we're really left with about a 2-month benefit. And so, I really want to see a little bit longer follow-up to see, if we're really changing the natural history or if we're just using a drug sooner.
So, Uday, I was curious what your thoughts were about this and if you have any questions with the faculty about it.
It's an interesting thing. I have 2 questions for the faculty about this. With this ctDNA, in adjuvant setting where there is no disease, how often do you check the ctDNA as a general hematology oncologist if this drug approved? Every 3 months, every 6 months? Does it increase the cost burden on the
Jane,
whole
any
system?
thoughts?
Yeah, I think that for most patients on this study, the ones we had at our institution, we were doing it every 3 months. There's a window that the study allowed. But that actually was one of the points that I was thinking I'd love to bring up is, not just the question of are we changing the natural history of the disease by introducing the CAMI earlier, but also what is that emotional burden on the patient if you're checking ctDNA every 3 months looking for this resistance mutation. Because for those patients who will do well on AI-CDK for a number of years, it adds a slight burden to them in terms of checking that blood test, waiting for those results. I think we have to take that into account as we think about which patients we're going to employ this strategy for.
Jane, are you thinking you'd like to be able to do that strategy right now?
I think, like Eric, I would love to see additional follow-up. I think that the trend in PFS2 is encouraging to me that we may be changing something for the better long term, but we don't know that yet. And I think the point about 2 treatments versus 3 treatments in that PFS2 is a really compelling one. There probably are some patients who are going to have ESR1 emerge as a mutation early that's going to be clinically significant. And I can see the benefit of making a switch before they become symptomatic or before they develop disease on scans, but probably not for everyone.
So, Uday, I was just kind of curious, what were your thoughts about it? Would you be inclined to want to do this or you want to hold off?
So the second question I have is the biggest thing is till now we've been doing the scans to say the progression of disease and all those things. This is the first time where we need to change the treatment on molecular progression. So that's one of the difficult things as a general oncologist who looks at the scans and says that this is the size of the tumor or there's a new lesion come in. How to convince the patient that look, this is a molecular progression we need to change? That's the difficult part as a general hematology oncologist in this study.
So I'll say, I don't think we've seen this before. It was really interesting. This is right after it was presented. I don't know what we'd see now. I'm even starting to see a little change in thought. But initially, what we reported at San Antonio was only about a third of investigators were ready to move forward with SERENA-6, but 2/3 of general medical oncologists were. I don't know what that means, but thought it was interesting. All right, let's continue.
So this is Persevera. Joyce has already alluded to this. So this was phase 3 of first-line giredestrant with palbociclib versus letrozole palbociclib. So really looking at upfront first-line with the oral SERD. And again, we've seen this press release in March of 2026 that it did not meet its primary objective of progression-free survival, but there was a numerical improvement. So this is really in contrast to what we saw with giredestrant in the adjuvant setting. And I think that this was maybe something that a lot of us were a little bit nervous about. Certainly this was a palbociclib combination, but, had palbociclib in both arms. So that's really not the issue here. The issue is giredestrant in the first-line setting in combination with a CDK4/6. And we've always had, some data that in combination with CDK, perhaps our endocrine backbone just doesn't matter quite as much. And so I think, this has a lot of weight riding on some of these other first-line combos, whether it's camizestrant, whether it's our other, oral SERDs of are we going to see a similar story, or was this trial maybe just a little bit too small, a little bit underpowered to show? But the question is I think we think that these oral SERDs are a better backbone, but is it strong enough to overcome the benefit we see in combination with CDK? So certainly looking forward to seeing the data here. These are the other trials that are ongoing. We have SERENA-4. This is palbociclib with CAMI. So very similar. As you can see, this trial has about 400 more patients. So, if they did have a numerical benefit, will this be enough to kind of make it statistically significant? And this Pioneera, giredestrant or fulvestrant with CDK and an endocrine resistant population population. This trial is currently enrolling as well. So I'll just briefly talk about PI3-AKT mTOR. Joyce is going to be talking about this in more of a resistant population. We know that this is a very common mutation, up to about 30-40% in our ER-positive patients. But we do have this in a first-line population as part of the INAVO 120 trial. So this is not all first-line patients. This is really a very cherry-picked population in the first line. These patients had progression during or within 12 months of adjuvant endocrine therapy completion. So really not your average first-line patient. And again, they also have the mutation. And you can see here that these patients did very poorly on endocrine therapy CDK alone. But when we added in inavolisib, really had a significant benefit. You can see that with endocrine therapy palbo alone, 7.3 months progression-free survival. So certainly not what we expect in the first-line setting in combination with CDK. But when we add in inavolisib, the PFS is 15 months. So I think very compelling for these high-risk patients that are progressing within 12 months of their adjuvant endocrine therapy completion. With anything great, it does come with a cost. There we see hyperglycemia, we see diarrhea, we do see rash, we see some ocular toxicities. This was approved in October of 2024, again for this high-risk population. And you can see overall survival, there is an improvement about 7 months here, but the pre-specified boundary for statistical significance was crossed. So INAVO 123, first-line inavolisib placebo plus CDK for endocrine sensitive. So this is the follow-on study saying, okay, well, if inavolisib had so much benefit for our patients that had endocrine resistance, what about for more of our all-comers that are more endocrine sensitive? And this trial is currently enrolling. We also have Capitello 292. This is capivasertib, so our AKT inhibitor, a little bit of a different flavor of hitting this pathway. This is with fulvestrant and CDK4/6 inhibitor. This is showing you some of the data from the phase 1b with Capi at 400 milligrams, really looking at Capitello 292 in a randomized phase 3 now, looking at fulvestrant CDK or fulvestrant CDK with Capi. So in summary, CDK in combination with endocrine therapy is superior to chemotherapy, even in our high-risk patients with high tumor burden and visceral disease. We know that oral SERDs in combination with CDK are under investigation in first line. We are starting to catch up in some of the other tumor types in terms of ctDNA-guided switching, but I would say that we're not quite there. This data is really emerging right now. And we also are getting more and more data in terms of PI3 kinase, AKT, mTOR, inhibition, and certainly it's still an opportunity for novel agents with improved side effect profiles. We have some drugs coming, like a PI3 kinase breaker that I'm very excited about, perhaps one of the drugs that I've actually seen recently that truly lives up to the cleaner, not so much side effects, which I'm very excited about. And, you know, we know that really with our endocrine sensitive patients that the sensitivity to hormone receptor positivity really is quite important with a mutational profile.
So, I'm sorry, go ahead.
So just leave you with an algorithm. It's even complicated now in first line. We certainly have different options for our patients with early relapses and PI3 kinase. And in second line, profiling is more important than ever, with different options for our PI3 kinase, our ESR1 mutations, and novel targeted agents here coming.
We're getting the algorithms we're showing this weekend are getting more and more complicated.
They sure are.
Amazing. So we're going to move on now, and Seth is going to talk about future oral SERDs and progressive disease. We're getting a flood of questions here, and particularly from the Zoom people. I guess people are getting up early today all over the country, maybe all over the world trying to watch this today, so it's awesome. We'll try to get to some of those later. All right, Seth, let's talk about SERDs.
Great, and thanks so much for the invite, Neil. You know I have an affinity for Florida, so it's great to be back anytime as I did some of my training down here. We're going to move on now into the second line setting and talk about SERDs and some of the new strategies. Here are my disclosures. And this is what we're going to cover in the next few minutes. We'll talk about elacestrant monotherapy in endocrine refractory disease in the EMERALD trial. We'll talk about imlunestrant alone and with abemaciclib, and then giredestrant and everolimus from the AVERA study. And then I'll just briefly touch on some of the platform studies looking at combinations of these drugs. And then I'll end with a similar algorithm oriented in a different fashion from the one that Erika just showed us. We've been talking a lot about these next generation antiestrogens. This was a nice article from a couple of years ago talking about the mechanisms of these drugs, and we're really zeroing in today on the selective estrogen receptor degraders in the middle here that bind to the receptor and promote degradation. But we have these other agents also moving through clinical development, new selective estrogen receptor modulators, proteolysis targeting chimeras, complete ER antagonists, and so that's, as you know, a whole nother hour of discussion for all of these exciting new compounds, both alone and in combination. But let's start with elacestrant. This really was the dawn of the field of these next-generation oral agents. This is the EMERALD study, and as we compare across clinical trials and do the thing we tell our fellows never to do here, we have to keep in mind some of the key differences in the study populations. The EMERALD was the most heavily pretreated population here. These patients were allowed to have had 1 to 2 prior lines of endocrine therapy. 100% had prior CDK4/6 progression. They were allowed to have had up to 1 prior line of chemo, and you can see 20 to 25% of them did get chemo. 40 to 50% of them had 2 prior lines of endocrine therapy. They were randomized to endocrine therapy, fulvestrant, or an AI versus the oral SERD elacestrant. And you can see the two curves here, the ITT on the left and the ESR1 mutant population on the right. All these curves have a similar pattern, the steep drop, 20 to 30% of patients on either arm really endocrine refractory. And then look at the tail, especially on the ESR1 mutant side, more than 20 to 30% of these patients are getting durable control just on single agent elacestrant, and the rest of the patients are in the middle, getting some modest benefit. In the ESR1 population, this led to an improvement from about 1.9 to 3.8 months, and this led to the FDA approval in that subgroup of patients. The authors went on to look at the duration of frontline endocrine therapy as a rough surrogate for endocrine sensitivity and saw that if you stratified patients based on the amount of time they had on their frontline CDK, the curves separate even further. So if you had at least 12 to 18 months on your frontline endocrine with CDK, now you're seeing a benefit from about 2 months up to almost 9 months with elacestrant monotherapy. And this is really the way most of us are using it in clinic right now for those patients who did better on frontline CDK4/6 therapy. They have an ESR1 mutation. They're probably the best candidates for the current FDA approval. And we've been talking about this, so I'm not going to belabor this point, but these drugs are very well tolerated. The grade 3+ toxicity rates are extremely low, on the order of 1 to 2% or less. The dose reduction rate on EMERALD was only 3%, discontinuation about 6%. And again, there's maybe some low-grade GI stuff that we're running into, some nausea, reflux, diarrhea. And here's some real-world data that my team generated alongside an independent study from Dr. Rugo and her colleagues. So this is based on huge claims databases across the United States where we can look at how long people are on drugs and some of the genomic factors that might be influencing that. So we had 2 studies done in parallel, and we kind of coordinated and published them together. Our team used the Guardant Inform database, over 700 patients who are treated with this drug after FDA approval. The Rugo team used the Komodo claims database along with the Foundation Medicine genomic database, over 300 patients. So more than 1,000 patients between the two papers. Very heavily pretreated, 50 to 70% prior fulvestrant, 40 to 50% prior chemo, 70 to 90% had visceral metastatic disease. And we looked at the time to next treatment, which is a surrogate for progression-free survival in these real-world studies. And we saw really a lot of similarity to the data I just showed you from the EMERALD subgroup analysis, about 6 to 9 months between the 2 studies. Not surprisingly, the earlier you used elacestrant, they seemed to do a little bit better in the second versus the third or fourth line. Patients who did not receive prior fulvestrant, again, seemed to do a little bit better. There was no impact with visceral disease. They did equally as well. And there were some interesting genomic findings. The patients who had concurrent ESR1 PIK3CA seemed to do a little bit worse. They fell off from that kind of 7 to 9 month down to 5 to 6 months, and that was true in both studies and also true in EMERALD. Patients who had ESR1 Y537S did just as well, and we know that that type of ESR1 mutation tends to behave a little bit worse, particularly with fulvestrant. And then interestingly, in our study, we found that patients who had higher degrees of polyclonality, meaning within the same patient, more than 3 or 4 different types of ESR1, they seemed to do a little bit worse. If they had 1, 2, or 3, there wasn't a big impact, but once you hit 4, which is about 10% of the population, they were falling off the curve a little bit. So that's hypothesis generating, and we're looking at that in more detail now. So here's the EMBER-3 study. Now look at the difference here. No prior chemotherapy, no prior fulvestrant, and 40% of the patients were CDK naive. Otherwise, the design for A and B were similar. Investigators' choice of fulvestrant or an AI versus imlunestrant, and then they added a third arm later, imlunestrant with abemaciclib. Here was the original primary endpoint. The shape of these curves are almost identical. No big difference in the ITT, but in the ESR1 mutant subpopulation, improvement from just under 4 months to 5.5 months. And based on this data, we have now an FDA approval that really matches elacestrant for single agent use with imlunestrant in the ESR1 mutant population. We had some updated data just recently published in Annals of Oncology from our friend Dr. Javeri and her colleagues. In the primary endpoint here, you can see an improvement from 3.8 still to 5.5 months. Overall survival, 23 to 34 months, really moving in the right direction, but not yet at target significance, and you can see those curves on the bottom. This is for the single agent. Here's for the doublet, imlunestrant, abemaciclib. We see an improvement in the ITT from 5.5 months with imlunestrant alone to almost 11 months with the doublet. And importantly, with the post-CDK4/6 population, we're still seeing 9 to 10 months. So these are patients who had progression on prior CDK, moving on to imlunestrant and abemaciclib, getting up to 9 to 10 months, but not quite as good as the overall population in the updated data. Now, if you look at ESR1 status, interestingly here, we see for patients who have ESR1 mutation with the doublet, they seem to do a little bit better, 11 plus months. If they have ESR1 wild type, they're still 9 to 10 months, but there's certainly a trend in a direction that we would expect. And then also with the PIK3CA, exactly the opposite trend, very similar to the single agent data. If they have PIK3CA mutation, they're falling off now to 7 to 8 months versus the PIK3CA wild type getting 11.3 months with the doublet. So we see a consistent trend that these patients who have PIK3CA in the endocrine resistant setting seem to be doing a little bit worse, both on single agent now and with these doublets with CDK inhibitors. And then again, toxicity here, you would expect with the doublet abemaciclib-driven toxicities with higher dose reduction and discontinuation rates for diarrhea and cytopenia, but no additional compound toxicity. The dose reduction rate for imlunestrant monotherapy was 2 to 3%, discontinuation 4 to 5%, very similar to what we saw as a single agent with elacestrant. And then lastly, for doublet therapy, here's the Evera study. Oop, you want to pause?
Sorry, before we get in, I was noticing when you were presenting your CCR paper in real world, Joyce was like locked in making notes on it. Yeah. All right. Anyhow, we were actually at San Antonio the previous year when EMBER-3 was presented again, and we were doing CME meetings asking the faculty, like, what do we do about this? What does it mean? So Jane, now we're a year plus later. We have imlunestrant now approved. Abema's already been approved, although I don't know the combination's actually approved, but I imagine you can get it. Are you using the combination strategy?
I haven't used the combination strategy, but I would be interested to, particularly in those patients that seem to benefit most. The ESR1 mutant, PIK3CA wild type, seem to get significant benefit with the imlunestrant abemaciclib combination. I have not used the combination yet, and again, like you said, I don't know if it's approved together, but I do think it seems like a really promising option for these patients, actually.
Erika, are you using it? Would you like to use it?
I haven't used it yet either. I've used SERD in combination with CDK as part of clinical trial, but I haven't used it commercially. I think you can get it, but yes, I mean, I think it is compelling. I think particularly for patients in the absence of mutations, it's compelling.
Do you see that SERDs are going to be used in combination in general in the future, Erika?
I think that they will be. I think that there's still a utility for SERD single agent. You add toxicity when you add combination. So, I think for those patients that have an ESR1 mutation, single agent is compelling just because of how well tolerated it is.
All right, giredestrant, everolimus.
And you can see the trend here. We're moving now toward more phase 3 prospective doublet data. And this is a really important study because it's the first doublet versus doublet phase 3 prospective trial with a next generation oral SERD. We're comparing everolimus with endocrine therapy of clinician choice to giredestrant with everolimus, up to 2 prior lines of endocrine therapy, no prior chemo, and they must have had a prior CDK4/6 inhibitor. And here's the data from Evera, and what you can see in the ITT population, improvement from about 5.5 to 9 months. In the ESR1 mutant subpopulation, the trend continues. They're doing a little bit better, up to 10 months. But there's a little bit of a trick here. The ITT is 55+% ESR1 mutant. Now, that's a lot higher than the 30 to 40% we would expect by kind of random chance. And when you do the subgroup analysis in the ESR1 wild type, so not the ITT, the 40-ish% patients who are ESR1 wild type, you see there's no benefit. So again, here, even with the doublet, we're seeing the benefit is exclusively limited to the patients who have the ESR1 mutation. And again, this is the same similar tox trial, except now we're adding everolimus. Discontinuation rate for giredestrant about 8%, for everolimus about 17%. You can see rare low-grade bradycardia related to the giredestrant, no real photopsia in this study, no big surprises compared to everolimus. And now we have a number of these platform studies moving forward looking at these drugs in combination with various agents. This is the Elevate trial, phase 1-2, looking at elacestrant combination with PI3K, mTOR inhibitor, CDK inhibitor, AKT inhibitor, and we're starting to see some data from the phase 2 portion here that we just saw at San Antonio from HOPE a few months ago. Here you can see elacestrant with everolimus, 8 to 9 months. Elacestrant with abemaciclib, 14 to 15 months. But not all of those patients were CDK pre-treated, and we haven't yet seen the data broken down by that. But again, we're getting these doublets. We're getting these numbers up into the 1-year range. It's very exciting and I think encouraging. Here's the Morpheus study, which our team is participating in. This is a very similar study, platform study looking at giredestrant combinations. Here's some data that was presented looking at giredestrant with abemaciclib and ribociclib. You can see there's responses across ESR1 and PIK3CA mutant patients. You can see some patients getting stable disease, some patients getting deeper responses. This is the phase 1 effort. We'll see more data as we accumulate larger cohorts here. And so here's my version of Erika's schema, just oriented in the opposite direction. And I keep having to change this now every few weeks with more and more prospective data. In the frontline setting, most people getting AI with ribo. We see the Innova 120 triplet in the appropriate endocrine refractory group. In the second line setting, we have the 2 oral SERDs for ESR1 mutant situation, olaparib for BRCA mutations, other PARP inhibitors, Capiva and alpelisib for PI3K pathway mutations, fulvestrant alone or with abema, everolimus-based therapies if you lack all of these other targets, and then ADCs and chemo. And then here I'm layering on the new phase 3 data where we don't yet have FDA approvals. We have the 1.5 line camizestrant switch. We have the vepdegestrant Protac that we don't have a label yet. We have doublet phase 3 data for imlunestrant, abema, giredestrant, everolimus. And I'm hypothesizing what I think the labels could look like based on the data with or without a specific genomic alteration. And then we have the gedatolisib data as a doublet or a triplet with this new next generation PAM pathway inhibitor. So Neil, I'm going to need either 2 slides or smaller font the next time we meet, probably later this year for a talk like this. So just to conclude, ESR1 mutations emerge under selective pressure. They're rare in primary tumors. We have elacestrant monotherapy activity and a label that seems to correlate with longer duration on the frontline CDK. I showed you the real-world data that really lines up nicely with the subgroup analysis from Emerald. We have the imlunestrant label as a single agent, and maybe we'll have future opportunities on label to use this as a doublet. We have giredestrant and everolimus. We don't yet have an FDA approval for this, and we have to put that in the context of lidera and persevera. It's very interesting what that drug might look like, both in the early stage and metastatic setting, and these drugs are well tolerated. So is there a role for monotherapy, and if so, who? How do we figure out which of those patients fall on the tail of the curve? How will early deployment in the adjuvant setting impact resistance? Which doublets and triplets are going to be the best choice here? Should we use them first line, second line? How do we look at patients who do not have actionable genomic alterations? Will there be a role for these drugs in that population? How are we going to use dynamic ctDNA monitoring like with SERENA-6? And we're having all these efforts to try to better predict ER dependence so we can help answer a lot of these questions if we had better genomic predictors. So thank you.
I was just flashing when we started Research to Practice. We had this graphic of how endocrine therapy works. It was kind of like this little Pac-Man tamoxifen going into the nucleus, and now we're like, wow, it's like really. All right, so let's just do a little sort of palate cleansing case. A couple of questions from the Zoom people. Hi to all the Zoom people out there, lots of people out there. So one of my favorite Zoom participants, Karen Green, has a case, Joyce, for you. Here it is. 63-year-old woman with history of stage 1 lung cancer and stage 2 breast cancer received adjuvant anastrozole and abema. Now 4 years into adjuvant anastrozole solitary met to T11. Going to get SBRT. Peripheral blood Garden is PIK3 positive, ESR1 and CHEK2 positive. What should she do?
Well, she's recurring on adjuvant AI therapy, and she's got a PIK3CA mutation. So she's, as long as her hemoglobin A1C is less than 6%, she's a navalisib candidate. She's had abema, but she's off the abema. So that was in the Nabo 120. Patients had not had a prior CDK4/6, but I'd be very tempted to offer this patient the navalisib, the Nabo 120 with a Nabo, Palbo, and fulvestrant.
What about the ESR1? What about a SERD?
Yeah, so we could potentially go with the imlunestrant abemaciclib. And it was interesting to see the updated data from 7.6 months or so there. So that's another option for her. And I do think we're going to end up sequencing these therapies. I think she'll hopefully get imlunestrant and abema as an option. So I think I'd have equipoise on those.
Jane,
Actually, let me say, anabolism has a survival advantage, so I would actually prioritize that if she's eligible from a hemoglobin A1C standpoint.
Jane, any thoughts? Any thoughts for Dr. Green? And also, Joyce mentioned hemoglobin A1C. Do you also use that criteria? If the patient has diabetes, will you try to push the hemoglobin A1C down and then treat?
Yeah, so I think these are really good questions, and I agree. I think I would lend myself towards the Nabo 120 in this situation because this patient did have abemaciclib, but she would have completed that 2 years ago if you think about the sequence of events for this case. And then also this is a patient who has what looks to be a limited recurrence, is getting SBRT. And so if the Nabo 120 regimen doesn't work or she doesn't tolerate it, you've got room to potentially pivot. I do use the A1C, and I think it's actually one of those interesting things now that we have all these new drugs emerging where hemoglobin A1C was an entry criteria for trials, where in patients who are on frontline AI-CDK or even adjuvant AI-CDK, it's an opportunity as we get to know these patients from a breast cancer perspective to also focus on some of the things that improve their overall health. And my experience is, especially in my population in the South, where a lot of patients come in starting with elevated A1Cs, that if we motivate them to get that A1C under better control, explaining that it will help their metabolic profile, but also could improve either their breast cancer treatment options down the line, they're more motivated. So that's something we often try to talk about with patients even before they recur, now that we know that some of these agents might be options for them later if their A1C is good.
Uday, we did an entire CME program just on glucose issues in oncology now, and it was really interesting. I'm curious how you think that through. And also, one of the things that came out there, I think I mentioned this yesterday, is the value of the on-body glucose monitoring system. Very easy to use. You really got a lot of granularity in terms of not only continuous hemoglobin A1C, but much, much more informative than just drawing fasting blood glucoses. What's your experience with that? And also GLP-1 drugs.
Yeah, so in as a general hematology oncologist, when you see the other drugs like in urothelial cancers and all those things where hyperglycemia is one of the biggest problems, I push the patient to get a CMG so that like continuous glucose monitoring is one of the things. And we have hard stops in the clinic. Like if the patient has more than 250 glucose or like, hemoglobin A1C is climbing up, we try to interrupt the dose or like, stop the treatment before the next treatment.
All right, so we're going to finish out with Joyce talking about PIK3, AKT, and mTOR. Joyce, we just did a program at the GU Oncology meeting. The urologists are now about to learn about capivasertib. We're going to talk about that later for prostate cancer. They were like, whoa. Here we go.
Awesome. Yeah, well, this is very exciting. We have lots of agents now to inhibit this very, very important pathway here. So here is the schematic of the pathway, and let's see. Oh, this is good. So we have PI3 kinase here, and it's got the enzymatic part of it, the kinase, and then we have the regulatory subunit. So this, you can get activating mutations. This is your PIK3CA activating mutations, and you can have loss of function mutations in P83. We're going to hear more and more about that. This is regulatory. When it's lost, you get loss of inhibition by PTEN, and you get activation of PI3 kinase, even though it's not mutant. So there's many ways to activate this, and AKT is downstream from PI3 kinase, and then TORC1 and TORC2 are downstream from AKT. And this is a key driver of resistance to everything we have in breast cancer. Very, very common. And here are some data in terms of how frequent it is. And this is metastatic disease, up to 45% or so, about 1 to 11 and 1 to 14%. In Memorial Sloan Kettering, they did the single center looking at metastatic samples of 41%, 9% for P10 loss, which leads to constitutive activation of the PI3 kinase, and then activating mutations in AKT were about 7%. With PIK3CA, we think of it more as a truncal mutation. It's present in the primary. It's present in the metastatic lesion. It's about the same. But P10 and AKT can also be in the primary, as you see, but also can be acquired. And PIK3CA can also be acquired as well. So this is something we definitely want to monitor with serial biopsies and serial CT DNA. So these are fairly common in the metastatic setting. So we now have the first of our AKT inhibitors. It's a pan-AKT inhibitor, capivasertib, and it is given 400 milligrams twice a day, and it is 4 days on and 3 days off to help diarrhea to abate. And in the Capitello 291, these patients were all AI refractory patients. You can see they could have had chemotherapy, but only 18% did. 70% had a prior CDK4/6 inhibitor for metastatic disease. Most had only one prior line of endocrine therapy. So AI pretreated. 38%, though, had primary endocrine therapy resistance. 68% had visceral metastasis. And they were randomized to what then was a standard of fulvestrant with placebo versus fulvestrant plus the AKT inhibitor, again, 4 days on and 3 days off, and they were eligible regardless of their mutation status. But this was tissue-based analysis of PIK3CA, AKT, and P10 loss to look at that subset of patients. And so here's the AKT pathway altered population, and here's the overall population. About 43% of the population was PIK3CA, AKT, or P10 loss. And you can see this hazard ratio here of 0.5, and it was 0.6 in the overall population, more than a doubling of PFS from 3.1 to 7.3 months, and a doubling here from 3.6 up to 7. But the benefit, really, if you look at those patients who were known not to have a PIK3CA, AKT, or P10, the addition of the capivasertib was very modest to the fulvestrant. So the AKT, the FDA approval was in the altered, the AKT, PIK3CA, P10 altered group. And we can see down the bottom here that whether the patients had P10, AKT activating mutations or PIK3CA mutations, the benefit was about the same. They all benefited. There wasn't a big differential benefit there. And I'm always glad to see what really works in liver metastasis. So you can see these point estimates. You can see all patients up here, the 0.6. This is the intent to treat population. But all of these subsets are basically lined up in that same zone, whether it was prior use of CDK4/6, yes, no, because 70% had it. Prior chemo, liver metastasis. This was good to see. This was really hitting this resistance pathway in some of our harder to treat patient populations. This blows up the prior CDK4/6 inhibitor data a little bit more. And you can see in patients who had not had prior CDK4/6 inhibitor exposure, they got up to about 11 months with the combination. If they had had a prior CDK4/6, it was still a big differential benefit from 2.6 to 5.5, but these patients do less well when they switch off of their CDK4/6 and AI onto the next regimen. Still, it's a big improvement. And so we saw these data from Nick Turner at San Antonio this year looking at ctDNA, and we could see those patients who had PIK3CA, AKT, or PTEN alteration in their ctDNA, and you can see that's even better. This is like, contemporaneous. Yes, we can find this mutation. Yes, it's probably making a big difference in resistance at this moment. And we can see this is a very good improvement in outcome with the capivasertib, even if they're ESR1 co-mutant, which is great to see. And if they're not, even better, but very, very similar here. And then we can see down the bottom here, if they alteration not detected, either on tissue or in the blood, you can see just really no difference in terms of the benefit from the capivasertib. So we really do need to find that mutant population. Now, capivasertib has a much less toxicity than alpelisib. For example, because most of the patients we're going to give capi to have a PIK3CA mutation. Diarrhea is the main toxicity, but with the 3 days off, it basically is very manageable. You don't really get it the first day on capi. You get it days 2, 3, 4, and you can use some loperamide, and then the patients stop it, and then it gets better. Hyperglycemia, very uncommon. Discontinuation rate low. Now, rash can be an issue, and I do definitely think we need to use the non-drowsy antihistamines prophylactically. I think that's really, really important. There are some patients that come off because of rash, but pulses of steroids can help as well to get rid of it.
Yeah, I wanted to actually get a little more into that, Seth, in terms of tolerability of capi. It's interesting, too. It wasn't just the urologists who had a lot, but the GU medical oncologists didn't know anything about capi as well. Interesting, too, that there is PTEN deletion. The other thing that came out in this study was those patients had a really poor prognosis. But Seth, can you provide a little more granularity in terms of tolerability of capi, particularly related to the rash and diarrhea, as Joyce is commenting on?
Yeah, I think we're moving in the right direction. When you look at these newer drugs, the newer PI3K inhibitors and capi compared to our experiences with alpelisib, for example, the rates of hyperglycemia in general are lower. And if you look at the table that Joyce was just showing, the rate of the high-grade toxicities are much lower. And I'm sure you'll talk about gedatolisib in a minute, and that moves even further kind of in the right direction, at least in terms of hyperglycemia. I think the 4 days on, 3 days off helps here, and most patients are okay with it. We make sure we start them kind of on a Monday or something so they can keep track and be consistent with it. Certainly, capi has taken over in the field in terms of the standard second-line approach, even for patients with PIK3CA mutations, because of the tolerability. But it is harder than an oral SERD, certainly as a single agent. And so this question comes up all the time. If you have a dual mutant patient, who should get the doublet, for example, with capi? Who should get the oral SERD? And there is definitely more toxicity with the doublet, more laboratory monitoring, more mucositis, hyperglycemia, rash, and some diarrhea, although we've gotten much better at anticipating these things. We'll use the antihistamine, we'll use Imodium, things like that. And for the most part, I think we're doing okay with it across the board.
Yeah, I think alpelisib is a traumatic experience for a lot of people. I know the day capi was presented and we did surveys, everybody was ready to switch, and they did. All right, Joyce, let's continue.
Okay, so we talked about the PI3 kinase AKT PTEN, and downstream from that is activation of TORC1 as well as TORC2. Now, everolimus inhibits TORC1. And when you inhibit TORC1, you lose this negative feedback. The S6 kinase turns off IRS and turns this off. The cell doesn't need both going. If TORC1's going because of upstream AKT or something, or your loss of C2. You get your TORC1 going. You don't need this going too, so that the cell turns it off. But then when you inhibit TORC1, you get reactivation. So you have a bypass pathway here. So then it makes a lot of sense to inhibit both TORC1, TORC2, and PI3 kinase. And so that is what gedatolisib does. Gedatolisib is an IV medication, 3 weeks on, 1 week off, once a week, a highly potent multi-target inhibitor of the PI3 kinase, AKT, mTOR, PAM pathway. Inhibits all of the isoforms you see over here of PI3 kinase. It inhibits TORC1 and it inhibits TORC2. So very powerful inhibitor of this whole pathway. So the Victoria 1 trial has reported here, and we can see study 1 is in the PIK3CA wild-type population. We have not seen the data yet in the PIK3CA mutant population. And these patients had progression on or after a non-steroidal AI and a CDK4/6 inhibitor. So all of them, they had measurable disease, which oftentimes to enrich for liver metastasis post-CDK4/6. Their hemoglobin A1C had to be 6.4% or less. No prior treatment with mTOR, PIK3CA, or AKT. No prior chemotherapy. And again, they were PIK3CA wild-type. 392 patients, 1:1:1 randomization, 3-way randomization to the gedatolisib, 180 milligrams once a week, 3 weeks on, 1 week off, with full dose palbociclib and fulvestrant. Arm B was without the palbociclib, and then Arm C was fulvestrant alone, but patients had the option to cross over to Arm A or B at progression, and PFS was the primary endpoint. And this is really a very stunning curve. We look at these patients here. We have this 40% drop-off with fulvestrant alone, and those curves split really very immediately. So this clearly points to the PAM pathway as the cause of this, or the major cause of this major drop-off. But 2 months versus 9.3 months with a hazard ratio we hardly ever see of 0.24. And this is quite durable. These patients are going out for quite a long time. So very, very important result. If we take the palbociclib out, we still have 2 to 7.4 months, so we still see excellent separations of the curve, highly statistically significant as well. Now, this is an interim. Remember that patients crossed over on the fulvestrant alone arm. They crossed over to get one of the two gedatolisib arms. And so we see trends here in survival, but then there's a sensitivity analysis. Again, this is just interim, but when you take out the patients, you censor the patients who at the time of crossover, then we see nice improvements in survival comparing fulvestrant to the triplet or fulvestrant to the doublet. Again, these are exploratory and still interim. And so with regard to tolerability, look at the toxicities in the bold. And we do see that there's issues here with stomatitis, gedatolisib. Now, with the palbo, it seems to be a little bit more. These patients were given steroid mouth rinses. We haven't seen the granularity of how adherent patients were. Did they start right away? Did they wait for stomatitis? How often did they take it? Does the stomatitis tachyphylax? So, I am told, I've not given the drug, but I'm told that it actually does tachyphylax over time and that it actually becomes really quite manageable over time. There is also some diarrhea, not very much high grade, but look at the hyperglycemia, as Seth said, very, very modest on the hyperglycemia here. So again, there is some rash, similar to everolimus toxicities here. So key messages, the PIK3CA, AKT, PTEN are mutated in 40, 10, and 10% of metastatic patients and really do drive resistance. Everolimus, exemestane, alpelisib, fulvestrant, and capivasertib fulvestrant are approved, and the future indication post-CDK4/6 will be the gedatolisib plus fulvestrant with or without palbo for the PIK3CA wild-type population.
So thanks, Joyce. I was just flashing on my old desk back when I had an office before the pandemic. It was like this huge desk. Everybody come in and meet around, looked out over Biscayne Bay in Miami, and then we built this podium for me, just like I do on my papers. And the entire thing right now is covered with questions from people, but here as well as on Zoom. So let me just breeze through a whole bunch of these. So Jane, this is actually from Dr. Flores, is going to be co-moderating the session later on lung cancer. She says the incidence of rising creatinine with abema. If I have a patient with adjuvant abema had to stop due to rising creatinine, would you use ribo instead? The patient had been on abema for about 2 months. I haven't heard about that. Increasing creatinine with abema?
You look at your. Did you have a question?
Do you know something about that?
There are.
Seth?
So yeah,
I can comment. Go ahead, Jane, first, then I'll comment.
You can go ahead if you want.
Well, no, I was just going to say we published a real-world paper on this looking at multi-institutional data with our onconephrologists, and you see more incidental creatinine elevation with abema that may be spurious. It has to do with secretion.
Oh, really?
Yeah, and so we've been using the cystatin C. Do you guys have that?
That was exactly what I was going to say.
Yeah, and the cystatin
It's a paper
C
toxicity.
Yeah.
It's nothing.
Paper.
It's not clinical. We shouldn't do anything with it.
Okay, Regina, you don't need
I guess what I would say about that, and I agree with everything you guys are saying. So the cystatin C is something you can use to monitor this, but what we've seen is that it's not a real toxicity in terms of actual kidney failure. And so probably in this patient, if it's mild, like stable creatinine elevation, you could look at that and potentially continue the patient on abema if they're otherwise tolerating it well. Some of the trials that we're doing now, we have one currently that's lasofoxifene versus fulvestrant with abemaciclib. There's actually cystatin C built in as part of the monitoring for that study so that we don't have to take patients off of the abema unnecessarily.
Interesting. All right, let me throw another one at you, Jane. Should any patient with hormone receptor positive breast cancer start endocrine treatment as soon as the ICH report, I don't know what the ICH report is, but I guess it's hormone receptor, becomes available, even T1, N0, M0 stage, time before surgery, they can get 2 to 3 weeks of therapy. They're going to get endocrine therapy anyhow. An advantage would be the psychologic effect. You're already starting treatment. Any thoughts about that one, Jane?
I think ICH is probably IHC, the immunohistochemistry.
Oh, IHC, yeah, right.
I'm not sure I understand exactly the question.
As soon as you see they're ER positive, even before they go to surgery, should you start hormonal therapy?
A couple weeks of endocrine therapy.
Not necessarily. I think most patients with ER-positive breast cancer, these cancers grow relatively slowly most of the time, and they can go to surgery and then start endocrine therapy afterwards. I think for many patients, especially if they have early-stage disease, you want to see what their pathology report looks like so that you can determine how aggressive you need to be with endocrine therapy. And I don't know that there's been any studies showing value for starting endocrine therapy right away preoperatively.
Not to mention, endocrine therapy choice is not necessarily going to be easy or straightforward in the future. You may need time to sort it out a little bit. All right, so several people, Seth, have brought up the issue of a patient with double, ESR1 and PIK3. This has been an issue ever since we started talking about this. I've seen people go back and forth. Usually when we ask investigators, we get all kinds of different answers. Right now, how are you approaching it, Seth?
Yeah, I think you could argue both sides of this, and I'll start with what I usually end with by answering here to say this is a temporary problem. All of this new data coming in, we're going to have in the relatively near future opportunities with better next-generation anti-estrogens and targeted therapies combined, some of these next-generation PI3K pathway inhibitors. With that being said, right now, I think it depends on the state of the disease, how well they did on their prior therapy, what the genomics look like, and who the patient is, A1C, medical comorbidities, functional status. If I have a patient who has relatively slow-growing disease or really minimal symptoms, who did well on the frontline CDK therapy, I'd like to try to give them the oral SERD because it's a lot less monitoring, a lot less toxicity. If there's more extensive disease, if the amount of benefit on the frontline CDK therapy was more limited, certainly less than a year, I'm thinking more about doublet therapy. All of these patients, to Erika's point, we have great clinical trials, and we want to try to get these patients on trials with combinations of next-generation agents like the ones that we've been talking about. But outside of a trial, I think it's extent of disease, how well they did on the frontline therapy, what's their A1C and their functional status, and we have to take it on a case-by-case basis. Both are reasonable answers.
Joyce, did you want to add to that?
I just want to make one point about the preoperative endocrine therapy. There's one really practical place that can help us based on the ADAPT trial from Germany, where 3 weeks of pre-op endocrine therapy is routine in patients, both pre- and post-menopausal. But if the Ki-67 has to be above 10% to start, and then if it gets below 10% with the 3 weeks of endocrine therapy, then those patients who do not get chemotherapy, now there are 0 to 3 nodes positive, and the 21 gene recurrence score is 25 or less. But those patients did not get chemotherapy, prospective phase 3 trial, and 5 years of follow-up, and there's no benefit from chemotherapy. So if you've got a premenopausal, we're not going to have the results of the offset trial for 10 years. If you've got a premenopausal patient and you're like, oh, this biology looks indolent, and I don't know if, but she's got 3 nodes or 2 nodes, and let me give her some preoperative therapy, and the better the endocrine therapy, very surprising, you can start your LHRH agonist and your AI at the same time, and only 3 weeks, and you're still going to get this big drop. They did 4 weeks for the LHRH agonist and AI, 4 weeks pre-op, do huge fall in these Ki-67s and these pre-mens, and they do very, very well, no chemotherapy. So look at that paper, the ADAPT paper. Nadia Harbeck is one of the authors.
So let me squeeze in one more question. This is from Masan in our crack chat room, Erica. 38-year-old woman, T2N1, ER positive, HER2 negative, status post neoadjuvant chemotherapy with TAC with good response down to T1. Post-surgery, 2 nodes positive, now ER negative.
Yeah, so it seems like you've eliminated, a ER positive clone and have some kind of residual triple negative disease. I think that patient, could get further chemotherapy. That patient also would be eligible based on the nodes to get CDK4/6 with endocrine therapy. I definitely would not omit endocrine therapy based on the fact that this patient was ER positive and node positive. Don't be fooled by the fact that there's some residual disease that's triple negative and underestimate the benefit of endocrine therapy here.
Interesting. Jane?
Yeah, I agree with that. I think I've actually had patients similar to this, and I think it's always a nuanced conversation about what we know and what we don't know. In this situation that I had that was similar, what we ended up doing was actually doing adjuvant capecitabine because the patient had neoadjuvant chemotherapy, and I wasn't going to give her more intravenous therapy, but then started her on endocrine therapy plus a CDK4/6 inhibitor. And we talked about the fact, of course, that there's no standard here, but that I felt she probably did have some residual ER positivity that wasn't popping up, and I didn't want to not target that strategy, but that if she tolerated the adjuvant capecitabine well, which she did, that was a reasonable thing to do as well.
So great job. We're going to move on now. Thanks so much.